I think that we are underestimating the importance of the induced astigmatism by the hand of the surgeon. Don't you have any recommendation? Because I think that everybody, I mean, not everyone, even if on the online calculator we should integrate this value. Don't you have any recommendation for people to?
Right. I mean, I think obviously you would want to use as small as incision as possible. Now, this is usually 2.2, 2.4 for most of the lenses which are on the market. And I don't think, if you go below 2.0, I mean, we've seen that typically what happens is that actually the wound gets stretched and it's actually larger afterwards. And so I don't think that makes much sense with most lenses on the market. So I think it's better to have a nicely done wound, limbal. So I go in limbal, so a little bloody, which is good because you also have some fiber and it closes the wound very nicely. And do your incision in the temporal axis, because if you're temporal, we're furthest away from the center of the cornea and we have the least induced astigmatism. Now, obviously, we also know there is variability, unfortunately. So that means, on average, the induced astigmatism is very little, but there are some outliers. And I think what's important is that, ideally, every surgeon for himself or herself should do a series of 50 or whatever cases where they actually do proper measurements before surgery, and then at 3 months after surgery, where you think the cornea is probably back to normal or back to what it's going to be, and to actually look at their induced astigmatism. And maybe change their incision style if they think that they're above what the normal average surgeon has. So I think this is obviously a little boring to do, but it's probably quite worthwhile at the end of the day. We do it because we have trials anyhow. In the trials, we see what comes out, so I don't have to do this extra. But for those who don't do trials continuously and don't have these measurements, in the box, and then I think it's something which is probably worthwhile doing.
There is some discussion here, I think, about using an absolute value for your surgically induced astigmatism, and you bring that into the equation. So when we have reviewed our data a couple of years ago, actually there was a clear relationship between the level of astigmatism and the surgically induced astigmatism if you're going to make the incision on that meridian. So a 1 diopter astigmatism versus a 3 diopter astigmatism, that's not going to give you the same amount of surgically induced astigmatism. It's much higher in the higher.
That's on meridian. That's
on meridian. And there are still people who use that as their preferred way of making incision.
But would you advocate to go temporal only?
Well, see, my concept is very clear on this. I use for a long time only temporal incisions, the smallest as possible, and try to do this because that's the best incision you can control in terms of astigmatism. We looked at our data. The induced astigmatism is 0.1 to 0.2. There are some outliers, you have to say, but it's really the temporal incision which makes it so. And we used on-axis and 12 o'clock, but I think for bringing this system to the most effective system, I like this very limbal incision as close into the limbus and temple, and then you can start calculating a little bit better. So that is a real good concept. Make it small, make it temple, and then try to do what Oliver said, get your 50 cases and look at your induced astigmatism. That's okay. Having said that, we will have some outliers. And therefore, one thing I really like to explain to my patients also, occasionally we have to do a touch-up. So we are refractive surgeons as well. We are actually doing refractive cataract surgery. And that is also going into the cornea occasionally. And occasionally you have to do a touch-up with a laser, which is then making those patients who are really unhappy with residual refractive error, put them in the category of becoming really happy patients.
But if you compare the, let's say, supratemporal or super versus temporal incisions, Oliver, what we've seen, we looked at that in the past, is that the spread is more or less the same. The standard deviation is 0.2, 0.25 for both. On average,
supratemporal with temporal, but not superior.
On average, it's lower if you go temporal, but the spread is the same. So the outliers, you will still have those.
Having said that, you still think that as soon as we can, do the incision on the steepest axis, if it's possible. Are you considering that, or whatever can happen, it's going to be temporal for all patients?
So I used to do that. I used to go steep axis in patients where I didn't do a toric just to reduce a little. I've stopped doing that, so I only go temporal now. And I just, but obviously you need to use torics earlier. I mean, especially if we're talking about presbyopia-correcting lenses, I think that's the strategy. Because like that, you keep the whole system quite constant. You don't want to change too many factors and too many variables, because then you don't know what the reason was for errors.
For my calculation, I found the same thing. I always go temple and have stopped using on-incision, and superior, I always go on-axis. The calculation is easier, although we still have outliers occasionally, but the calculation is just easier because you take out something out of the equation. The induced astigmatism, you only have it temporally, and I think you can control it better. It's also surgeon preference, but I think that works very well.